Doctor, did you follow up on that patient?
Yeah, but I'm studying this mid-sagittal MRI of a disc herniation.
The intervertebral disc contains a superficial fibrocartilaginous annulus fibrosus which surrounds the deeper gel-like nucleus pulposus. The intervertebral discs are located between vertebral bodies and absorb shock during flexion and movement of the body. With excessive load from lifting injury, trauma, or tissue degeneration, tears in the annulus fibrosus appear dorsolaterally due to its thinner lamellae that occur from the absence of supporting ligaments. In disc herniation, the nucleus pulposus obtrudes from the torn annulus ring around the posterior longitudinal ligament posterolaterally and into neighboring tissues. Symptoms include nerve impingement, pain, and inflammation to neurotissue. In the affected patient's MRI, the herniation is posterior to the intervertebral disc and is the clearest difference in comparison to the healthy patient. This global health issue occurs most commonly at the lumbar region, where it affects 2 to 3% of the population.
Why do these intensities differ?
Well, let me show you. Well, tissue water content dictates its MRI signal intensity. The higher the water tissue concentration, the higher the signal intensity. Proteoglycans are negatively charged proteins composed of multiple branching glycosaminoglycans, in which resist compression by repelling against each other, spreading the tissue while attracting water into the tissue. 50% of the nucleus pulposus dry weight is attributed to proteoglycans. Hence, there is also a high water component. This high water concentration provides the nucleus pulposus under a T2 weighting with a high intensity signal. The annulus fibrosus dry weight is composed of 70% collagen and only 20% proteoglycan, therefore containing a moderate water quantity. This low water quantity compared to the high collagen composition portrays an intermediate signal intensity in a T2 MRI. But is this the best modality?
Although radiography is cheapest, soft tissues aren't clearly demonstrated. In scanning a disc herniation, it's vital for the nucleus pulposus to be visualized. In radiography, the unsafe X-ray beams penetrate the soft tissue with limited absorption that results in a semi-radiopaque, superimposed and inconclusive result.
CT provides less detail of soft tissues, as together the annulus fibrosus and nucleus pulposus present as a singular semi-radiopaque structure. Although the CT attenuates more detail to bony structures with a radiopaque appearance, these hard structures are not major diagnostic features necessary to diagnose intervertebral slip discs.
MRI is used to view soft tissue structures, hence being the optimal modality for visualization of a herniated intervertebral disc. Specifically, a T2 weighted MRI with fat suppression is most applicable, as the bone marrow is proximal to the subcutaneous fat. This allows for an enhanced visualization of a herniated disc.
Let's take a look at misdiagnoses.
It is due to the common symptoms of lower back pain and sciatica that a herniated intervertebral disc appears clinically similar to other underlying pathologies. However, the most similar presenting pathology is that of spondylolisthesis. To differentiate between a herniated intervertebral disc and spondylolisthesis, a plain radiograph and a T2 weighted MRI of the vertebral column can be compared. Spondylolisthesis describes an abnormal anatomical alignment due to the degeneration of two vertebrae, as seen here in this lateral plane radiograph. In comparison, when we look at this T2 weighted MRI, we can clearly see the herniation of the intervertebral disc. Approximately 85% of patients who present with lower back pain and sciatica are found to have a herniated intervertebral disc.